Removing an epidural, this is Dr. Ken Bohennick for AskDrBo.com. Well, the first thing that one needs to do when they want to remove an epidural is to have an order. It's not something that you want to go after all by yourself and try it on your own. So, if we have an order, as we have on this example right here, you'll see it is checked off, actually in this case defaulted, that the RN may remove the epidural catheter after a 4-hour recovery period. So your first question is, why are we waiting 4 hours? Very simply, to allow the anesthetic to wear off. They're dealing with epidurals for labor in this particular talk, in this particular order, actually. And so we want the local anesthetic to wear off so there aren't any untoward permanent effects from removal of the catheter. So don't be so bold that you think you can remove the catheter without an order, or you may find yourself in court defending that particular action. The tape is the easy part. Now, you're going to find about as many different methods of taping as there are anesthesiologists out there. Actually, all of these go straight up the back, which is the exact opposite of how I personally tape it. But the purpose of this slide is just to show you there are varied methods of taping, and the idea is to take the tape off without disrupting the catheter so that you can carefully remove the catheter once the entire taping mechanism or process is removed.
Now here's an example of taking the tape off of an epidural catheter. You might notice that this catheter is coming off to the left side rather than going straight up the back. That's just the way that I personally tape my catheters. Our attempts will be to remove the tape without removing the catheter at the same time. Now some people will try to take it all out in one fell swoop, and if the patient still has residual anesthesia and the epidural catheter is around a nerve root or some other structures in the epidural space, you can pull right through that by using that technique. So as you'll see here, we try carefully to remove the tape while preserving the catheter in place, and in the subsequent video you'll see us remove the catheter itself. I personally think that's a much safer way to do it. Yes, it does take more time, and perhaps peeling the tape off slowly like this is a little more uncomfortable for the patient, but I think in the long run, for their safety, this is the preferred method.
The challenge begins here. Here we have the tape off. You see some residual, what appears to be betadine around the area, but cleansed in the area where the catheter is coming out of the skin. And this is where it all starts.
Now, this is a quick clip showing once the tape is taken off and the foam padding, an attempt to pull the catheter meets resistance. When this happens, stop immediately and call a physician. Make sure the anesthetic is worn off before you even attempt this, and call a physician.
Most people would think, well, just grab the catheter and pull it out. Well, you can, and in many cases you'll get away with that. And I'm saying get away with it because on a very rare occasion, and it's not unheard of, I've not seen it in my practice, but it certainly can occur, you can have an epidural catheter around anteriorly around the spinal cord. You can have an epidural catheter tied in a knot. You can have an epidural catheter around a nerve root, where much of the danger lies that if the patient still is anesthetized and it's tied around a nerve root, aggressively pulling that catheter may in fact pull it through the nerve root without the patient even feeling it because they're still anesthetized. If the patient is non-anesthetized, they're going to feel a paresthesia like you wouldn't believe if you start pulling on it and it's around a nerve root. In addition, it may not come out very easily. You may find resistance, or you may find an inability to remove the catheter entirely, and we'll address that here in just a couple slides. Resistance or pain on removing could be a narrow space. In a very thin patient, sometimes they're flexed maximally to have the epidural placed, and once they deliver, they're ready to get it out. But now, instead of flexing the back to open the inner spaces, they're sitting straight up, and makes it much more difficult to remove the catheter. This most simple answer to a catheter that won't come out, and there is no pain involved, but it just won't come out, call the anesthesiologist to remove that catheter. It's their ultimate responsibility to remove the catheter. You're actually doing it as a favor for them to remove it in the first place. As I said previously, we could have a knot. We could be tied around a nerve root. Don't pull while the patient's anesthetized, especially if there's any resistance. Many of these catheters are made of substances that are similar to Teflon impregnation, and they should just slide right out with a minimal amount of effort. If it doesn't, then something else is going on. So with pain or resistance, stop. Call someone to help you.
Continuous pressure applied to the epidural catheter will allow it to come out of the skin in the epidural space very easily. Upon removing it, take a look at the tip and make sure that it is intact, and document that in your nurse's notes or physician notes, depending who's listening to this lecture. Apply a Band-Aid over the puncture site and ask the patient to continue to wear that Band-Aid for approximately 24 hours after it is applied to allow at least sufficient healing to minimize the risk of infection for her or him if it's a male patient. And that's pretty much all there is to it.
With no pain or resistance, well, it's a different story. So assuming you have the order that you can pull it, and assuming after you take the tape off of the patient, the catheter just continues to come out with no resistance in a continuous fluid type motion, you're good. I generally recommend you grab the catheter about 1 inch from the skin of the back. That gives you maximal leverage in removing it. Pull gently and continuously until the catheter is completely out. Carefully place a Band-Aid over the site and ask the patient to continue to wear that Band-Aid for about 24 hours afterwards. Obviously, 48 would be great. 24 hours I see as a minimum, allowing the body to heal. Examine the tip of the catheter and make sure that it is intact. Document the fact that the tip was intact when you remove the catheter in the nurse's notes. Any questions, or if the tip is not intact, again, contact the physician involved in placement of that catheter. What if this was your catheter? And this is believed to be, from what I read, an actual catheter that was removed with some difficulty. And this could be it. We have vascular catheters that tie themselves in knots in large blood vessels in the body. Why wouldn't a epidural catheter do the same? It's not predictable. It's not common by any means, but it can happen. So always consider that when you're planning to take out a catheter. Now, a second ago, we talked about removing the catheter and confirming that the tip was intact. This particular slide, I put blue circles around the tip of each catheter. And as you'll see, looking at many different brands of epidural catheters here, the tip of all the different brands is colored. So when you pull a catheter out, look at the tip. In some of them, it's actually a different color than the markings that are on the remainder of the catheter. But you should have a color right at the tip, and that verifies that the catheter has come out intact. We tried some experiments years ago to deliberately fracture catheters, not in patients, but outside of patients. And it's proved to us to be impossible, but I know somebody somewhere can do it, and somebody somewhere has, as I've read articles on that. So it's important that we document not only that you remove the catheter and the time, but also the fact that the catheter tip and the catheter was intact in doing so. Expected post-epidural symptoms, point tenderness at the puncture site. If you recall, once you remove an IV, that site is going to be tender after an IV is removed for 24, 48 hours afterwards. A average epidural catheter for labor, for example, goes through either a 17 or an 18 gauge catheter. Well, think of a 17 or 18 gauge needle going in for an IV. That site is going to be sore. So too is the site on the back going to be tender right there. But it should be localized right to where the point tenderness is. If there have been multiple punctures on the back, you're going to have multiple areas of tenderness. You may have some backache if the patient is postpartum and you're removing a catheter. That's not uncommon. Remember that loosely defined hormone they call relaxin that circulates during pregnancy, allowing the patient's position or posture to change as the center of gravity changes, is immediately removed from the patient's system upon delivery of the baby. So it's going to be gone. The back is tightening back up again. And also, obviously, contraction of the uterus, maintaining contraction to minimize bleeding, causes referred pain to the back as well. So some backache is not uncommon. Decreased sensation until the block weans. If the epidural has been running for 6 or 8 or 10 or 12 hours, the patient's going to have residual anesthesia even after you turn off an infusion. So let's allow sufficient time, and then we would expect the block to wear off in a continual fashion. Decreased temperature sensation accompanies the sensory block. So if we're testing the patient with an alcohol wipe, an ice cube, a cold instrument, or something like that, we would expect a temperature differential, and we would also expect it to recede as the block does as well. And removing the catheter, depending on the duration of the infusion, you may get 1 or 2 or 3 drops of a clear solution coming back through the puncture site as well. Clear is the key, and about 1 to 3 drops. If the epidural has been running for a long period of time, the epidural space is pretty filled up, and the lymphatics can only take off so much per hour. So if we're running high volumes at high rates, the fluid is going to take the path of least resistance and will track back along the epidural catheter depending on the infusion rate and the volume that's being administered. So that's something like that is not unexpected. What would be a symptom of concern would be fever and chills in the patient. Now, obviously, that can be from endometritis or a myriad of other causes, but we always have to suspect a potential for an infection in the epidural space. Severe backache involving the entire spine is more concerning than the point tenderness where the epidural was placed. Neck stiffness or neck rigidity, actually, is another indicator of potential for meningitis, and so that should raise your index of suspicion significantly. Any neurologic deficits, be they sensory or motor, after the block should have worn off or has worn off, and if there's a residual neurologic deficit, again, contact the anesthesiologist immediately. If we have persistent numbness or persistent weakness or purulent drainage from the puncture site, obviously we would want to culture that purulence and see if we can culture the bacteria. If we see some of these signs before the epidural catheter is removed, we would want to culture the tip of the epidural catheter. So in most cases, a simple way to do it is to open up a suture removal kit, which has sterile scissors in it, and you have your culture tube. As you draw the epidural catheter out, do not touch it to any substance, but using the sterile scissors, clip off the distal centimeter or two of the epidural catheter into the culturette tube and send it for culture and sensitivity, and that would help us determine if they're just contaminants or a full-fledged infection. Contact a physician as soon as possible. Don't let the sun set on this problem. If you suspect that we do have a problem with a potential infection in this patient, there's no question about you need to contact the physician. As I said, if the catheter remains in, we'll be culturing the tip. If you don't feel comfortable doing that yourself or your hospital policies do not allow it, then get all the materials at the patient bedside for the physician, because that's what he or she will be doing upon their arrival. We'd like to have good IV access, as if we're suspecting infection, antibiotics are going to soon follow, so it'd be nice to be a couple steps ahead of the game and assure that the patient has a functioning IV before calling the physician. Unfortunately, the epidural space does not have the best in immune function. So there was a study, I believe it was 38 documented epidural abscesses throughout the world literature. And if I remember, only 2 or 3 of the 38 had even had an epidural injection or an epidural catheter placed. The epidural site, as I said, is not known for its immune function, and patients with a septicemia can develop an epidural abscess because of that lack of immune battle. So that's basically it. Just a few minutes it took to explain this whole procedure of removing epidural catheters. This is Dr. Ken Bohenik. Always remember, we have a happy patient with safe practices. We hope to have you come and visit our website and listen to a few more of our lectures. Until that time, thank you very much for listening.